Yeah, so thank you very much. I'd like to thank all the dignitaries on the dais and the AIOS as well as the APOC, the Andhra Pradesh State Ophthalmic Society for inviting me. I have no financial disclosures. I have changed the topic slightly because Dr. Lahani so eloquently described pediatric cataract surgery. So my talk is going to be on IOL implantation in infants, to do or not to do. So when you look at a child and you're planning a cataract surgery in a child, there are certain issues that we have to consider. One is the fact that it's a much smaller eye. There tends to be a significant amount of inflammation postoperatively. Calculation of the IOL power is more challenging because the IOL power formulae that we have, they're actually for adults and not for children. And so the age of the age at which we're doing the surgery also matters because the eyeball is growing and then you tend to have refractive surprises. They tend to have PCO. There's a lot of proliferation onto the anterior hyaloid face and they tend to get PCO. They also tend to develop glaucoma and they develop amblyopia, which is the main reason why we want to do the surgery sooner rather than later. So the surgery per se, I think I'm not going to go through all the details. Dr. Lahani has described it in very well in his previous talk. So what we have to understand is that the capsule is very elastic and we need to make sure that the rhexis covers the optic. It should be 5 millimeters and you do it with the help of a rhexis forceps. And the other thing that we have to ensure is that you make a PPC which is a little smaller because you need to have a gap between the anterior capsule and the posterior capsule enough to accommodate the intraocular lens. When you're putting it inside, it doesn't fall into the vitreous cavity. And we always land up suturing. So I'm not going to cover anything about the surgery per se. But when you're operating a child, and previously we used to leave these infants aphakic, they used to wear aphakic spectacles. You realize that these are bulky glasses. Sometimes the glass actually touches the eyelashes of the child and it becomes a little problematic. They also have a constricted field. For monocular aphakia, unilateral cataracts, this is obviously not an option. So the other option for managing these infants is using contact lenses, which have been there since 1959, but the silicone contact lenses that we use are the ones that have revolutionized this, and these lenses are very useful, very easy for the mother to handle. So they're safe. We can keep changing the contact lens based on the power, and there are certain issues with results with respect to the maintenance as well as with the cost over time, but they do give very good outcomes, particularly if you institute amblyopia therapy simultaneously, and there is a minimal risk of infection. The intraocular lenses have been used very widely for children over 2 years of age, and their long-term safety has been established. The only thing that we're concerned about, of course, is because we put the IOL in the bag, we have to make sure that the posterior hyaloid face remains clear, the visual axis remains clear over time, which doesn't always happen. The power has to be modulated, as Dr. Lahani pointed out, to accommodate for the age of the child. So now, what do you do for infants? What do you do for somebody who's less than a year old? And the IATS that was conducted in the US actually was a multi-center trial by Scott Lambert's group, which actually started looking at a comparison of the intraocular lenses in infants. They implanted these lenses over 12 centers. It was a multi-center trial between 1 to 6 months of age. So that was an age when you thought, can we actually implant an IOL inside the eye or not? But they did a study where they looked at the IOL with glasses versus contact lenses. Now, what they found was very important because they found that there was no difference in the vision at 1 year, not much difference at 4 or 5 years either. And there were several papers that came out from the IATS study. But they noticed that there was an increase in the intraoperative complications in the IOL group compared to the contact lens group, because of if you're putting an IOL in the bag, then there are issues. There's iris prolapse intraoperatively, there's a larger incision, you have to suture that. Whereas if you're leaving the child aphakic, you don't have to do that. There were more adverse events in the IOL group with lens epithelial cell proliferation, membranes, correctopia, compared to the contact lens group. They landed up obviously doing more surgeries in the IOL group versus this. And obviously, if you're going to do additional surgeries, you're going to pay the parents have to incur a greater expense. So there's an increase in the cost involved. And the younger the child you operate, there's a higher risk of glaucoma, which is something that we have to be very aware of. Simultaneously, there was a study conducted in the UK where they looked at IOLs in children under 2, but they took up to the age of 2, and what they found was that bilateral cataracts, younger age group had a high risk of glaucoma, and those who had microphthalmos, so unilateral cataracts with microphthalmos, there was a higher risk of glaucoma. So one has to understand that if you're going to put an IOL in a child and they are very young, so between 1 to 6 months of age, then the chance of glaucoma is much higher, which means that the follow-up in the postoperative period has to take this into consideration, and we have to keep checking the intraocular power. And we have to keep checking the refraction, make sure that you're changing the glass power based on that, and keep checking the intraocular pressures, because they may develop glaucoma which we may miss. And if there's a shift in the refraction, more of a myopic shift, increase in the actual length of the eyeball, increase in the white to white, these are all the signs that we have to keep looking for, which would give us a clue that the pressure is on the higher side, and control that appropriately. They may require additional surgeries, the anti-glaucoma medications that we instituted, and we have to keep a track of these kids. So it should not be that we do a fantastic cataract surgery and then lose vision because of glaucoma that sets in. So in summary, based on the data that we have, that I've just presented to you, the intraocular lens implantation does have adverse events, does land up having additional surgeries that need to be done post-operatively. So for very young infants, this may not be the best way to go. Probably for kids above 6 months, I think an intraocular lens can be implanted. For the ones less than 6 months, we could probably leave them aphakic. And additional surgeries may have to be done, particularly if you have to clear up the visual axis over time. The risk of the glaucoma that I mentioned is definitely there, and therefore it's important to keep these kids under very close follow-up with regular examination under anesthesia, measurement of intraocular pressure. We could use the eye care tonometer to measure pressures, but it's important to subject them to anesthesia to get a more accurate assessment. Thank you very much for your patient hearing.
Thank you, Dr. Mal. I think you have covered very well. What she says, it is 1 to 6, it is difficult because you get the complications. But what is discussed now today is, after 6 months, when the axial length of the patient is more than 17 millimeter, in such cases, you can go for the IOL.
Yeah.
So that not before 6 months, but after 6 months, where the contact lenses is difficult, the patient is from the rural area.
Yes.
In this situation, when it is a 17, you can go ahead, and now I will thank